Okay, everybody. Uh, Hello. This is Dr. Marston, and we are moving on with class number 5. And this week we are going to talk about confidentiality, and we're going to talk about advertising. Uh, Advertising, I always find interesting because I think it's much more of a issue than people might think it is when it comes to psychological services. Before we move on, I want to just pick up. I did leave not quite enough time last class to talk about the one ethical principle that was. Uh, that was in the previous section under human relations, and that's this whole issue of dual relationship. So I just wanted to pick up a little bit more about that before we move on to other um, parts. Um, okay. And I thought, even though I know you had the chance to read it, I thought it would be very useful to go back to the actual definition in the ethical principles about what constitutes multiple relationships. So I'm going to be, it's 305. Uh, um, a multiple relationship occurs when a psychologist is in a professional role with a person and one is at the same time in another role with the same person. Two, at the same time is in a relationship with a person closely associated with or related to the person with whom the psychologist has the professional relationship. Or three, promises to enter into another relationship in the future with the person or a person closely um, associated with or related to that person. So that's so a multiple relationship. But if you look at the next paragraph, one thing that's very important is those are what constitute multiple relationships. But the very next paragraph talks about not all multiple relationships are a problem, and that's kind of where things can get sort of dicey. I mean, you will have all sorts of disagreements about people who, can you see a client's cousin? Can you see, your landlord's next door neighbor? I mean, there's all sorts of um, issues come up. I do a lot of assessment work with children and will work to help their parents better understand how to help their children. And then maybe once my role is over, I will be asked if I can see the parents to help them deal with the stress. I do a lot of disability evaluations. I work for the court. And then when I'm done with that work, I'm often asked to uh, when I'm done with that role, I'm often asked to maybe see the person for therapy, so that I am, so that person is still coming to see me after the assessment is done. In that case, usually, um, in that case, what I will do is I will tell them that whatever work I'm doing for the court involving them, once that's done, then there's not a problem with me seeing them for therapy. Now that wouldn't be a multiple relationship uh, because it's the same person, but it would be taking on dual roles, which sort of falls under the same category. But notice how the second paragraph: a psychologist refrains from entering into a multiple relationship if the multiple relationship could reasonably be expected to impair the psychologist's objectivity or effectiveness, and that's where multiple relationships become a problem. Um, and um, and then if you look at the third part, multiple relationships that would not reasonably be expected to cause impairment or risk are not unethical. So so there's that part to it that I just wanted to make clear. Not all that it's very important to realize that not all multiple relationships are a problem. as I said, as I made reference to at our last class, and we'll bring up a little bit more here. Um, um, the issue of multiple relationships where I practice becomes up because it's a small community. And in small communities, sometimes people um, in a number of different roles. So, um, and in my area, I have at least one major and one minor insurance company where I know that I'm the only provider for a good distance. So someone would have to drive pretty far to see someone else if they have that insurance. So that becomes an issue for them where I'm at, and it becomes sort of um, a sort of what causes the most harm if I see them, even if I also have another relationship with them, or um, that I refuse to see them, and then they have to travel long distances to see someone else who will take their insurance. So it's always a debate, and it's really that issue of will the relationship impair your ability to be effective and or objective, and that's really what you're looking at when you want to make a decision about a dual relationship. Okay, so let's move on then to uh, confidentiality. And I'm just going to have the book out here because I just want to make clear which ethical section I'm looking onto. Sorry, the pages are stuck here. Give me 1 second. Okay. Um, so we talk about let's first section we're going to talk about is confidentiality. Um, confidentiality covers a large degree of concern in the role of a psychologist. In large part because what we talk about with people are so um, personal. It's interesting to keep in mind that several years ago, I guess it's been about a decade or more now, there was a big movement towards privacy. HIPAA came out, the Health Information Portability and Privacy Act. And HIPAA basically defined the expectations with regards to privacy and confidentiality for all healthcare professionals. What was interesting, and it's called HIPAA, HIPPA. What was particularly interesting about that was at the time, there was very little in the HIPAA law for all healthcare professionals that psychologists weren't already doing. Most of the confidentiality rules under HIPAA, psychologists already had in place. We had already, these were already part of our ethics. The ethics here in the book that we talk about, Maintaining Confidentiality. Um, this book was published in 2008. That was before HIPAA. So all the thing, if you look to the confidentiality section and then compare what confidentiality rules came up with regards to HIPAA, they're equal. And I guess it's been more than 10 years, and this probably was written around the time HIPAA. But HIPAA was finalized after this, and we were already doing this long before HIPAA because psychologists have always had a strong emphasis on confidentiality, that the information we have on individuals do not get shared with anybody else. I told you a few courses ago, even about our issues of confidentiality are taken so strongly that we are the one profession, well, mental health, psychologists, therapists, generally, a therapist, we are allowed to keep a type of note that is not subject to HIPAA. HIPAA allows individuals to um, request their own records and allow the steps for them to get your records, if you're a psychologist and a therapist, to get your records released to somebody else. But there is a type of note um, called a psychotherapy note, also known as a process note, not a progress note, but a process note, um, where the psychologist can put down their own thoughts about where they were going with the therapy, their own impressions of the person, and that is not subject to a release of information form. Those can only be released with a court order signed by a judge. Um, so we are allowed to hold those back. And it just shows you how much confidentiality has its importance in psychology, because even our own thoughts about what is going on is not something that we're required to release because it's so confidential, considered so personal. Now it's our own thoughts, but it's our own thoughts about the client. And the general thinking behind that is other people don't need to know in detail what we were thinking about um, with the um, with the client. And it's interesting, if you think about some of the things um, that may come up in therapy. Um, uh, you could see where this importance of having a process note and being able to keep even that separate from what else is released. Because we deal with some stuff that you pretty much would have to be another psychologist to understand. One that comes up a lot are dreams. Uh, somebody comes in and says, I had a dream last night, and in the dream, I was in jail for shooting my neighbor. Well, we know that that doesn't mean the person wants to shoot their neighbor. Dreams mean a lot of complicated things. Rarely do dreams mean what we're actually dreaming. But if you put that in the note and it ends up in, the person um, goes through, say, child custody hearing and they want their notes released, you know, that that can sound pretty bad on them if there isn't another psychologist there to explain, what a dream like that might mean. Um, I you know uh, I do a lot of testing, and when you do testing, you might use the ink blot test, the Rorschach. I use something called the thematic apperception test, similar to the Rorschach, where you show people uh, uh, pictures and they have to tell a story about what's going on. And sometimes people's stories can get kind of violent, kind of bizarre, but that doesn't mean that they're bizarre or violent. There's a lot of themes that can come up for different reasons. Some of the pictures pull for more violent and bizarre content. So confidentiality, I just bring that up because it's very interesting to keep in mind that one, confidentiality as reflected in HIPAA and some of the recent privacy laws were stuff psychologists were doing long before. And much of the stuff that we talk about in therapy is so confidential that we are the one profession allowed to have these separate notes that don't have to be released, even if other records do have to be released. Now, in many ways, confidentiality is, I know there's a lot of sections in here, and we can go through each of them. But in a lot of ways, confidentiality for psychologists is reasonably straightforward. You don't share if it's an adult, if somebody's 18 or older and they are not deemed incompetent, um, then we don't share anything with anybody else unless they give us permission. I told I think I told this before, but it bears repeating. One of the more interesting experiences I have with clients is if I'm working with someone as a young teenager, um, and so maybe I'm working with them when they're 13 or 14, and then they come back to see me when they're like 18 or 19. And maybe they still come back because their parents pressured them, said, you're having some problems. Why don't you go back and see Dr. Marston? And I will ask them permission to do things, or I will ask them if they're okay with things. And they'll say, well, why don't you just go ask my mom? And I'll have to tell them, look, you're 18 now. That no longer applies. Your parent is no longer the decision maker. You are the decision maker. Now, you can give me permission to go talk to your parents, but in the end, you're the one who has to make the decision. You're the one who um, signs the paper. I know in the um, I know that in the previous classes we've talked at times about this sort of gray area between the ages of 12 and 18, where individuals, depending on the state, can give their permission for things. Um, Even if they are still, legally a minor, legally under someone's care. Um, but what's noteworthy in this part of the discussion is that 12 to 18 is the gray area. Once a person's 18, there is no gray area, unless, like I said, unless they've been deemed incompetent by the court. Um, and only if they've been deemed incompetent by the court. Everything else is they're 18, they're the decision maker. I think, as I mentioned before, I work a lot with older individuals, and it will be interesting because um, I'll ask them questions and they'll ask me if I called their son or daughter, and I'm like, I want to tell them no. I will if you want to give me permission to do it. If you want to request, I do it, but I don't automatically call your children because you're still legally your own decision maker. So we keep everything confidential. We do not share information unless we are given permission, and unless certain circumstances are are in place. And I'm going to tell you, here are some of the exceptions where we do share information. And what's interesting, I'm pulling what I have up on my other computer screen right now is my information, my privacy practices form that I have every patient sign. And I thought it'd just be interesting because I have on there um, what why I might share information. In fact, I have a statement right before the list of exceptions where I say there may be times where I have to share information about you with an outside source. Some of these situations include, and here are some examples of uh, where there might be a need for me to share information. Uh, the most noteworthy one is if I feel the person is in danger to themselves. If I believe they're suicidal, and at that point, as I said, in this state where I'm at, I would have to alert the crisis management agency or the local psychiatric hospital, who would then evaluate the person. In some other states, I could be the one admitting the person to the hospital. But if I feel a danger, that they are a danger to themselves, if I feel that they're not suicidal thoughts, but actively suicidal, I get called into a lot of medical facilities to do evaluations where the staff will be worried that the person who's suicidal because they said something like, I wish I would just die, or I'm ready to die. That's not suicidal. Um, Suicidal is I'm going to kill myself. Saying I'm ready to die is not only not suicidal, but if the person's, if they're in a nursing home and they're 80 plus years old, or if they have cancer, saying I'm ready to die may actually be a sign of acceptance, psychological strength, because they may very well be dying. So, saying I want to die or I'm ready to die is not being suicidal. But if the person is actively suicidal, if you believe they have a plan and they have an intent, um, another example where the person's not suicidal is a person. you know I go into medical facilities, nursing homes, primarily, where I'll hear people say, if I had a gun, I'd kill myself. Well, you're in a nursing home, you're not going to have a gun. Or if we were in a tall building, I'd jump off. Well, you're on the first floor of a building that has only one floor. So so again, that's not suicidal. But actively suicidal, you can release information to the authorities. If you believe someone specific is in immediate danger by your patient, that's another time that you can release information. We talked a little bit ago about the ethical, the situation that led to that rule, where there was a woman who was being hounded by a man who was in therapy, and he ended up killing her. And the therapist was deemed to be someone who should have let this woman know that she was in danger. Now it's when there's a specific threat, and you are responsible as a therapist to not only let the authorities know, but to let that individual know that they could be in danger. So if you believe someone else is in danger, if you believe a child is being abused, this is another one that's in my form, because if you believe that there's a child who is being abused, then you're allowed to alert the authorities. What's interesting is in every state, you can contact the child authority and report a case and not get in trouble, even if they decide not to investigate the case. So when you work with children, you always want to err on the side of caution. Um, Excuse me, finding uh, throat was a little dry there. Now, it's interesting. It's interesting to keep in mind this thing about having to contact, if the authorities, if you think there's child abuse, because you would think that would be pretty straightforward as far as people being accepting of that, but that has actually gotten a lot of criticism, because most states have made it so easy for psychologists to report suspected child abuse or concerns about child abuse, that they require the psychologist or therapist to report if there's any concern whatsoever. And that's actually gotten some criticism, because you have a client who comes in, you you get concerned from things they said, that they're hitting their child, and uh, maybe hit them once or twice, harder than they should. You deem that. Well, you would be obligated to report if you feel it was harder than just sort of your standard spanking, or then you would, if you would be obligated to report it, even if it was pretty clear that it was a mistake, like it wasn't a pattern, the thing just got out of control in a bad situation or two. You'd still be required to report it. Well, what tends to happen is, even though it's anonymous, your client's probably going to know. They tell you about hitting their kid, you finish the session, 2 days later the child authorities show up at their door. Well, they know who reported. They can do the math, even if they won't tell them. Well, now you probably have lost that person as a client, because even though you're ethically allowed to report it, they're probably not going to be happy that you reported it, and in most circumstances will probably drop out of therapy. So what happened? You reported something that in the end was probably a mistake, and you may even know in the end the child authorities aren't going to do anything because it was clearly a mistake. But now, the one thing that could have helped this parent keep that from happening again, being in therapy, they're going to stop, because they're going to be upset that they were reported when they didn't really think they did anything. So that's just an interesting thing. But so there's always that concern when you report a parent for any sort of child behavior that you may very well lose them as a client. And even if that's not something you're concerned about for your practice, and it certainly shouldn't be, you want to do what's right for the kid. That's the most important. But you could very well be doing something that's going to cause that parent to no longer be in therapy. So the help they were getting to prevent that from happening again, they're not going to be getting. So, but it's something you have to do. So, also, by the way, I mentioned that you can, that you're allowed to break confidentiality if you feel that that there's a child in danger. You also are allowed to break confidentiality if you believe that there is a dependent elderly person in danger. So elder abuse. One other situation I have in my form as far as uh, breaking confidentiality, it's important to let people know that you're allowed to share information with their insurance company if they're using insurance, because the insurance is going to require certain things before they pay. And they're going to require certain information like diagnosis, um, and possibly severity of the diagnosis. And they may follow up to get copies of your notes. I have in there that I want people to understand I am allowed to share that information if they want to use insurance. Sort of the standard thing to let people know is if they don't want their insurance um, to know that they're coming, then they should just pay out of pocket. And if they pay out of pocket, then their insurance company doesn't have to know anything. But it is a requirement that the insurance company is going to want certain information before they pay for services. Okay, so that's when you can break uh, confidentiality. Um, and it's important. You will notice it, and right now I'm on 402 because you will notice how what I just went through was about making sure the person is informed about when it's okay to break confidentiality, because that's important to know. It's important to know um, uh, it's important to know when confidentiality can be broken. And in fact, that's why I have this form here, because I have people sign it uh, to document that they were informed of when I might be able to break confidentiality. So now uh, the rest of the sections all kind of relate to that. But I wanted to spend a little bit of time on 406 consultations, because that's an interesting thing that we made reference to, um, but didn't delve to it. There's a difference between consultation and supervision. Supervision is when either you are supervising an unlicensed person or you are being supervised as an unlicensed person. If you are in training and practicum, it's supervision. When you have a license and you are working with the student who is in training, then you are the supervisor. In the other case, you're the supervisee. Consultation is different. Consultation is when um, you consult with a colleague, or a colleague consults with you, and you're on an equal level, but you consult with somebody who may have more experience in an area and you want some feedback and some guidance on how to do it. It's a sort of benefit from their experience. I told you before that where I sometimes provide consultation is I'm considered an expert in autism, and sometimes I'll have consult from people who um, uh, uh, need help understanding autism. When I started out, um, it was an interesting experience. Let me tell you, this is When I started out in practice, my area of specialization was geriatric psychology, people over 65. And it was a relatively new field at the time because insurance companies had just started paying for it. So it was interesting that my first job out of graduate school was one where I was being supervised by somebody else because I didn't have my license yet. So generally, I was super, but I was also acting as a consultant for some other professionals because I had a particular expertise in geriatric psychology that they didn't have. So legally, I was being supervised by someone else because I didn't have a license, but I was also providing advice, guidance, suggestions to other professionals who were licensed but didn't have as much expertise in working with people over 65 as I did, even at that point in my training, because I had specialized in it. Um, so um, uh, so consultation is a different role. Consultation is where you are an equal and you are providing consultation to an equal. And uh, so the rules that are in this section on consultation 406 um, um, has to do when you're in consultation role. Because again, with consultation, if you're a supervisor, if you are supervising someone or you're being supervised, you basically have to give that person every piece of information that you have. Because if you are being supervised by someone, um, they basically are they're the licensed person. So they're the ones, they're basically seen as the primary clinician. You're working with them, but they're seen as the primary clinician because they have the license. Um, so when you're a supervisee, you've got to tell this person everything. Consultation, it's more limited. You don't have to share, and you're not expected to share more than um, than is necessary. When I provide consultation, it's usually the case that um, they won't necessarily even tell me the person's name because there's no real need for me to know their name. Um, they don't need to break that aspect of confidentiality because my knowing that person's name isn't going to matter in terms of my being able to give advice. I need to know about the situation. I don't need to know the person's name. If I were the supervisor, I have supervised clinicians who are unlicensed and I have the license. I do need to know that person's name because they are essentially my client. Um, the supervisee is the one providing the service, the therapy, but ultimately what they do and the outcome is my responsibility as a licensed person. That is not the same with consultation. So consultation, you try to keep the information limited as much as possible, only an as needed basis. Now, there's other aspects of therapy that are important to know. There, some are mentioned there. If you are giving presentations um, about different cases, you don't disclose any information that would identify the individual to someone else. Um, you do not um, you do not tell someone uh, information during a presentation that would even let them know um, where the person lives, what general, what specifically where they live. You try to keep the information as general as possible and only provide uh, uh, sufficient information to make your point. That's kind of where this research is the same way. Research, if you're using research, unless you have permission from the individual to provide specific information about them, identifying information about them, you keep it as general as possible. It's interesting that some of these ethical principles about presentations, research, um, articles, books, all kind of fall into the same pattern. You don't, and consultation, you don't provide any more details than what is absolutely necessary to address the points that you need to address. Okay. So we went through the part about confidentiality, and I think that's all very important material to keep in mind. I want to now move on. So that's section 5. No, I'm sorry. That's section 4 of the ethics code. Now I want to move on to standard. I call it section 5. It's standard 5. And it's about advertising and other public statements. Up until just a few decades ago, it was considered unethical for psychologists to advertise their service. We weren't allowed to advertise, and that's, I mean, it's been a few decades, but it, maybe the '80s. It started the ethics code allowed for it more, and then it became formalized in this one. But but it hasn't been that long that it was considered unethical previously to advertise um, therapy, and it's allowed now, um, but there are a lot of rules that you have to follow, a lot of ethics. Um, and in fact, one of the reasons why advertising has been allowed more is because advertising was seen as a way of getting more marginalized communities to be aware of what services would be available to them. So, uh, psychologists in their advertising are often encouraged to make clear when you have something that might be of particular interest to people in more marginalized communities. If you have um, experience with certain sexual orientations or certain socioeconomic backgrounds, or if you speak a second language, or any of those things, that's the sort of thing that is even encouraged to be in advertisements. Not that you can guarantee um, any sort of outcome, but to help people from more marginalized communities feel more comfortable that, hey, here's somebody who might be able to help me. Um, so psychologists are encouraged to reinforce that in the advertising. It's seen as a way of getting information out there to people. But on the flip side, you have to be very careful that you are not overemphasizing um, your field of competence. Bottom line is, if you give the impression in your advertising that you have experience in, or you have specialization in, or expertise in, you have to be able to prove it if someone were to ask you about it. You can't say, for instance, that you're an expert in trauma therapy if you have no experience in trauma. Um, so with advertising, you stress your experiences and skills that are going to be of most interest to the clients. You can be open about your education and publications and things that you have done. Um, but you don't use that to um, you don't use that to stress a level of competence or a level of expertise that you do not have. Um, it's also very important with advertising and therapy that you make it very clear that what you're doing is an advertisement. Sometimes there's a fine line, especially with professionals. are you actually advertising your service, or are you doing some sort of public service announcement? You have to make clear that what you're doing is advertising. So you don't misrepresent your business. You make it clear it's advertising. You do not misrepresent your skills or your level of expertise in certain areas. Um, you, advertisements also for psychologists have to be um, general. And what that means is you can't target specific individuals for therapy. You can't try to convince people that they need your service. And that's probably that's probably the general statement that's sort of consistent throughout these ethical principles is um, uh, when you advertise, you're pretty much letting people know that here's a service that could help, and here's someone who's available to do it, but you are not trying to convince someone that they need therapy. Um, you're basically with advertising, you're saying, if you decide you need therapy, here's why you should consider me, but I am not going to use advertising to convince you that you need therapy. Can be a fine line there. Can be a fine line about, if you're talking up your practice, how are you not convincing someone that they may need this service if they have that uh, sort of problem. But it's a fine line, but it's a line that you cannot use therapy to convince someone they need therapy, but you can use it to convince them that if they think they need therapy, then you're the person that they should use. Um, Notice, I mean, the ethical principles here are pretty straightforward. You don't use false advertising, you don't um, misrepresent your credentials, um, that sort of thing. Um, One particular area that I find interesting when talking about therapy is the use of testimonials. And there's another one where it's brought up here. Testimonial. Oh, and statements by others. Um, you have to be very careful about that. You cannot solicit testimonials from clients. You can use them if they give them to you. Um, um, I had a, I do, um, I do video therapy, and I'm on a couple of video therapy sites where people can sign up for video therapy, and one of the sites allows individuals to write their testimonials of their therapists. Um, I had one that I really loved. I loved the testimony. It just really reflected how I do therapy, and I forget exactly where what it said, but it was something along the lines of, um, "Dr. Marston was tough, but I really needed that at the time." So, or something along the lines of that. Dr. Marston is tough, but I really need that. Um, and I like that because it's kind of how I don't try to be confrontational in therapy, but I push people a little bit. I tend to confront them on things, no more than they're able to handle, but I try to push them a little bit. That was a testimonial I've used in different places. I can use it because I did not ask for it. The opportunity was there on the site, but nobody was required to use it. This person chose to put that on there. So, testimonials you can use, but um, they can't be solicited. Same with, and what this is what I was looking at for the book here. Um, 5.02 statements by others. Um, you cannot require someone who works with you to make any sort of statement about you. If they choose to make a statement about you, you are allowed to use it, but you cannot solicit it. Um, what I also liked about uh, what I also liked about 505, the one about testimonials, um, is notice how it ends. Psychologists do not solicit testimonials from current therapy clients or patients or other persons who, because of their particular circumstances, are vulnerable to undue influence. I like that because not every ethical principle makes any sort of statement about why it's considered to be unethical. In this case, they do. It's because if you are trying to get testimonials from current clients, um, then um, they are subject to undue influence. You also can't do it from past clients, but here it's specifically mentioned current clients because they are subject to undue influence. Um, they may tell you what you want to hear because they think it will make you happy as their therapist. And very often people want to make their therapist happy. Um, especially if you think of the issue of transference, you one of your purposes in therapy may be to get the person to not feel such a strong need to make everybody happy. And you may get them there, but in the meantime, if you're asking them to give you a testimonial and they're feeling uncomfortable about turning you down, then that's causing problems for them. And they may give it just because they are trying to make you happy. So you can't solicit testimonials. You can't solicit statements from people you work with. Um, they can give them freely of their own choice, but you cannot solicit them. I also wanted to talk about how it's mentioned a couple times in here that um, if you are making an advertisement, you have to make it clear that it's an advertisement. It has to be clear any material that you have um, is um, is um, is an advertisement. It has to be clear it's not some sort of academic document, that it's not a position paper, that it's not a research study, that it's an advertisement, that you're advertising your service. You have to make clear of that. Uh, the last point I wanted to make about advertising in therapy is how far do you go as far as talking about results? If you think about it, you can't promise someone that they're going to get better. Um, so you have to be very clear and very careful when you're writing an advertisement um, with regards to how far you are going in terms of telling the person that this is going to help, because therapy is not a guarantee. And so, um, you know, I example we have around here that I've seen a couple times of somebody who um, comes close to the closest, probably works the finest line that I've seen as far as just not crossing over into any problematic area when it comes to therapy, but coming close is a psychologist. I actually know this person um, who's a therapist, but does a lot of hypnotism, and he will do he's gotten testimonials from sports people and, some pretty famous people around here to do testimonials for him. That's fine. They say, help me quit smoking, help me gain confidence, that sort of thing. Um, but what he does is has a money back guarantee. So if you pay for his stop smoking seminar and then you don't stop smoking, you get your money back. It's not promising results, but he's saying he's so certain you're going to have results that he will give you the money you paid back if you don't. Um, Now, the reason that probably doesn't come closer to actually breaking the line is people aren't out money. If they go and they don't quit smoking, then they can get their money back. But that's kind of close to promising results. And you have to stay away from that. You can tell someone that you think you can help. You can tell them you're listening. You can tell them that you will do your best. You can tell them that you will use um, only scientific approaches. I have a website, and I don't know that I advertise, but I have a little blurb on there where I try to get people to know something about me. And all of my marketing materials, I stress that I use scientifically backed approaches. I use a lot of cognitive behavior therapy, a lot of therapy that's really strongly um, supported by the clinical research. And but I don't guarantee results. I just say I'm using the approaches that the scientific research says are most likely to get positive results. So that's also, it's not guaranteed, it's not promising results, but it's saying I'm using the approaches that are most likely to get results. Um, so that's an example. You can go kind of that far, or you can go far enough where you say, I'm really sure I can help you, but if I don't, if I'm wrong, I'll give you my. That's probably why that one works with getting the money back, because it's the person saying, I really think I can help you. I could be wrong. And if I am wrong, I will give you your money back. Okay. I will look forward to seeing everybody Friday morning. Uh, See you then. Take care.